So welcome guys. In today's session, we'll be looking at the knee joint, and by the end of this session, you should know which type of joint is the knee joint. You should know the articulating surfaces of the knee joint, the capsule attachments and the ligaments of the knee joint. We will look at the knee menisci, the stability factors, the neurovascular supply, relations and movements of the knee joint. Welcome all. My name is Wallace Munyeri, and I'm the Yuda Daktari. So let's start. Knee joint. It is a synovial joint, being the largest one in the body, and it is a modified hinge joint. Why modified? Because hinge joint, remember hinge joint allow extension and flexion, but hinge joint can allow some degree of rotation. So it is a modified hinge joint. It is also a compound joint in that it is composed of three joints. We have the lateral tibiofemoral joint, medial tibiofemoral joint, and the patellofemoral joint. Those three joints form the knee joint. Now, here we are. This is the lateral side. This is the lateral tibiofemoral joint, medial tibiofemoral joint. Then here we have the patellofemoral joint. The tibiofemoral joints, both the lateral and medial, both are condylar type of joints, where the patellofemoral joint is a saddle or a sellar type of joint. So, which are the articulating surfaces? Now, the articular surfaces of the medial and lateral femoral condyles articulate the articular surfaces of the medial and lateral tibial condyles, okay, to form the tibiofemoral joint. So, the medial femoral condyle will articulate with the articular surface of medial medial femoral. Sorry, let me start again. The articular surface of the medial femoral condyle will articulate with the articular surface of the medial tibial condyle to form the medial tibial-femoral joint. Okay. Then the trochlear surface of the femur articulates with the articular surface of patella to form the patellofemoral joint, which is a saddle-sellar type of joint. Let's see them there. Now, here we are. You can see this the lateral femoral condyle articulating with the lateral tibial condyle with the lateral meniscus. Lateral meniscus intervening to form this now is the lateral tibiofemoral joint. Okay, then here you can see the trochlear surface of femur articulating the articular surface of patella to form the patellofemoral joint, which is a saddle-sellar type of joint. Okay, same here, same here. Okay, now capsule and ligaments. Now let's start with the capsule. When discussing the capsule, you should know the capsule attachment to the femur, and that is what we are going to do now. Posteriorly on the femur, it is attached to the proximal margins of the femoral condyles and the intercondylar fossa. Medially, this capsule is attached to the articular margin of femur, but laterally, the attachment is higher since it lies proximal to the groove or popliteus tendon. Anteriorly, this capsule shall blend with the patella retinacular and is attached to the sides of the patella tendon or the patella ligament and patella. Okay, then the capsule anterosuperiorly, the capsule is deficient to permit the communication of suprapatellar bursa with the joint cavity. Okay, now tibial attachments are as follows. Posteriorly on the tibia, the capsule is attached to the margins of the tibial condyles and in the intercondylar area to the distal edge of the groove of attachment of posterior cruciate ligament. Now, on the lateral condyle, its attachment is interrupted by an aperture for the passage of popliteus tendon. Now, on the side that is both in the lateral and medial, the capsule is attached to the margins of the tibial condyles, and laterally is also attached to the head of fibula. Okay, then we have a thickening of the capsule on the medial side, and that thickening forms the deep component of the tibial collateral ligament, and its family that thickening is attached to the medial meniscus. Okay, now on the deep aspect of the capsule, we have fibers from the capsule which attach the rims of the both menisci to the tibia. Is like they anchor the knee menisci onto the tibia. Now those fibers form the coronary ligaments. Okay. Now anteriorly on the tibia, the line of attachment on the tibia of the fused capsule and the patella retinacular usually incline distally from medial and lateral condyles to the tibial tuberosity. Now a diagram to show you that. You can see on the what is important here is that on the anterosuperiorly, it is deficient to allow communication of the suprapatellar bursa with the joint cavity. And, okay, then you can see here on the lateral condyle, we have the groove for passage of popliteus tendon. Okay, then you can see here anteriorly on the tibia, they are inclining distally to be attached to the tibial tuberosity. Sorry, this should be tibial tuberosity, not patella. It should be the tibial tuberosity here. Okay. Okay. Now, the other ligament, tibial collateral ligament, or the medial collateral ligament of the knee. Okay, it is flat, triangular band attached above to the medial femoral epicondyle. This is the medial femoral epicondyle here where it is attached. Okay, then this anterior margin, that is its proximal attachment is the medial femoral epicondyle. Then its distal attachment is to the upper part of the medial surface of tibia. Okay, then this is the anterior margin of the ligament, which is free except at its attached extremities. Then the posterior aspect here, this is the posterior apex of the triangular ligament, usually blend with the capsule. This is the one which forms the deep component of the tibiocollateral ligament, which forms a thickening in the capsule, and that thickening is attached to the medial meniscus. Now we have the fibular collateral ligament, which unlike the medial collateral ligament, also the other name of fibular collateral ligament is the lateral collateral ligament of the knee. It is cord-like, okay, which is attached proximally to the lateral epicondyle, okay. Then distally, it is attached to the head of fibula with the tendon of biceps femoris muscle overlapping it, but there is a bursa which is interposed between the two. Okay. Now, the ligament, unlike the medial collateral ligament or the tibial collateral ligament, it has no attachment to the capsule nor to the lateral meniscus. As it is cord-like, okay, and no attachment to the meniscus nor the capsule. Okay, you can be asked to state the differences between tibial collateral ligament and fibular collateral ligament. You can. That's a possible question. I hope you have understood. Now, oblique popliteal ligament. Oblique popliteal ligament is an expansion of semimembranosus muscle that blends with the capsule at the back of the joint, and they usually ascend laterally to the intercondylar fossa and lateral femoral condyle. Now, oblique popliteal ligament is pierced by middle genicular artery, a branch from the popliteal artery, and the middle genicular nerve, which is a continuation of the posterior division of obturator nerve into the knee joint. Okay, and here it is. You can see this semimembranosus. Then you can see it is ascending laterally. Okay, and it is pierced by those two structures. Very in fact, because there is middle genicular artery, middle genicular vein, and then now the nerve, the neurovascular bundle. Now, don't confuse the oblique popliteal ligament to the acute popliteal ligament, which is Y-shaped thickening of the posterior capsular fibers, with the stem of the Y is attached to the head of fibula. Here it is. This is your acute popliteal ligament. You can see the stem is attached here. Then it has two limbs. Now, the medial limb, this medial limb here, you can see the medial limb. It is arching over the tendon of popliteus. Okay, and some muscle fibers of the popliteus muscle are attached to it. Then the lateral limb is somewhere here, usually ascend to the lateral femoral condyle together with the popliteus tendon. Okay, so it has a medial limb which is arching there, and a lateral limb. Then the stem is attached to the head of fibula. Now, cruciate ligaments. Even if you forget the other ligaments, please don't forget cruciate ligaments, which are two. We have anterior cruciate ligament, posterior cruciate ligaments. But before we reach there are a pair of very strong ligaments which connect the tibia to femur. Now, they lie within the capsule of the knee joint. So they are intracapsular but extrasynovial. Please understand that statement. Intracapsular but extrasynovial. It is as if they have been herniated into the synovial membrane from behind. So they are covered by this synovial membrane only anteriorly and on the sides. Posteriorly, the synovial membrane is deficient. Okay. Now, the anterior cruciate ligament is attached to the anterior part of the tibial plateau between the attachments of the anterior horns of medial and lateral knee menisci. Now, this ligament usually ascend. It usually ascends posteriorly and laterally at the same time. So posterolaterally, twisting upon itself to be attached to the posteromedial aspect of the lateral femoral condyle. Okay, what are its functions? When discussing the function of this cruciate ligament, look which movement it prevents. Which tibial movement does it prevent on femur relative to femur? If you want to understand. So the anterior cruciate ligament will prevent the anterior dislocation of tibia on femur. That is how I usually use them to not confuse. But if you are preventing the anterior dislocation of tibia on femur, it's like you are also preventing the posterior dislocation of femur on tibia. Okay, whichever you might use, both are correct. Now, posterior cruciate ligament is stronger, shorter, and broader than the anterior one. It is attached to a smooth impression on the posterior part of the tibial intercondylar area, which extends to the uppermost part of the posterior surface of tibia. Now, the ligament, this is how it ascends. Unlike the anterior one, this will ascend anteromedially and to be attached to the anterolateral aspect of the medial femoral condyle. Okay, what are its actions? Said, consider which movement it prevents, which tibial movement does it prevent relative to femur. So if it is the posterior one, it will prevent posterior dislocation of tibia on femur, or it will prevent the anterior dislocation of femur on tibia. Same thing. Now, cruciate ligaments usually cross each other like the limbs of the letter X, so they form a cross. Now, under the name cruciate. Here we are. This is the anterior cruciate, and it usually ascend posterolaterally to be attached to the posteromedial aspect of the lateral condyle. Then posterior cruciate usually arise anteromedially to be attached to the lateral aspect of the um, uh, medial, and this one. This is what we are saying. This is the posterior cruciate. It will ascend. This is the medial side here. So it will ascend anteriorly and medially, anteromedially to be attached to the anterolateral aspect of the medial femoral epicondyle, and they will cross each other like an X. Okay. In fact, here you can see this is the attachment of the posterior cruciate, and you can see they are somewhat forming an X. Now, this is the attachment of the anterior cruciate, posterior cruciate, and you can see they are lined. They are within the capsule, but extrasynovial. You can see the synovial membrane covers the in front and the sides only. Okay, it's as if they have been herniated into this synovial membrane from this side, from the back. Okay. Now, meniscofemoral ligaments. Now, fibrous bands usually arise from the posterior aspect of lateral meniscus. Okay. If the fibrous band lie anterior to the posterior cruciate ligament, that ligament will be known as the anterior meniscofemoral ligament of Humphrey. But if these fibrous bands which are arising from the posterior convexity of the lateral meniscus lie posterior to the posterior cruciate ligament, they will be known as the posterior meniscofemoral ligament of Risberg. I hope you've understood that. Okay. So, and you cannot have both of them at the same time. So it is either you have the anterior one or the posterior one. The transverse ligament usually is a variable band which connects the anterior convexity of the lateral meniscus to the anterior horn of medial meniscus. Okay, this is your meniscofemoral. And you can see in this case it is lying posterior to the posterior cruciate ligament. So this is the posterior meniscofemoral ligament of Risberg. In the other times, it might lie anterior to the posterior cruciate ligament. It will be known as the anterior meniscofemoral ligament of Humphrey. Now, knee menisci. Please understand this. Now, knee menisci, formerly known as the semilunar cartilages, they are fibrocartilaginous, okay, and they lie on the tibial plateau, and they are anchored onto the tibial plateau by the coronary ligaments. They are usually triangular in cross section, but their periphery is thicker. Now, the menisci are mainly vascular because this is cartilage, except for the peripheral zone, which are vascularized by the capillaries from the capsule. Now, medial meniscus. Okay, please understand that the medial meniscus is the one which is semicircular, almost a semicircle. It is broader posteriorly. Now, the anterior horn of the medial meniscus is attached to the intercondylar area in front of the anterior cruciate ligament, where the posterior horn is attached similarly in front of the posterior cruciate ligament. So, both the anterior and posterior horns are attached anterior or in front of the respective cruciate ligaments. Now, as mentioned above, the medial meniscus is firmly attached to the capsule, okay, and the tibio-collateral ligament. Please remember that. Now, lateral meniscus is about 4/5 of a circle of uniform width. Okay, I want you to be looking out for some differences between the two. Now, its anterior horn is attached in front of the intercondylar eminence of the tibia, but behind the or posterior to the anterior cruciate ligament. Then, and it usually partly blend with the anterior cruciate ligament. Then the posterior horn is attached behind the intercondylar eminence, also in front of the uh, posterior horn of medial meniscus. Okay, let me show you that. You can see now this is the medial side. You can see that the anterior horn is arising in front of the attachment of the anterior cruciate ligament, and the posterior horn is also attached anterior to the attachment of posterior cruciate ligament. Then you can see the lateral one, the posterior horn is in front of the attachment of the posterior horn of medial meniscus. Then the anterior horn of the medial meniscus, sorry, this is the lateral, the attachment of the anterior horn of the lateral meniscus is lying behind the attachment of anterior cruciate ligament. Then you can see the differences here. Please look at them. Then functions. To summarize the functions is that the knee menisci are important in shock absorption, weight transmission. They also have a proprioceptive function, and they also contribute in joint stability because they usually increase the concavityness of the tibial condyles for better congruence with the femoral condyles. Now, here you can see that this one is forming 4/5 of a circle. So this must be your lateral meniscus. Then this is a semicircular one, is the medial one. Okay. Then you can see this this ligament here. This one, this is a transverse ligament. Okay, it attaches the anterior horn of the medial meniscus to the anterior convexity of the lateral meniscus. Okay. Then here is your anterior cruciate ligament. This is your posterior cruciate ligament. Please understand that. Now, stability factors, there are two categories into two, either dynamic When you say dynamic, you're talking about muscular and muscular factors mainly, and then static stability factors. You're talking about bony factors and ligamentous factors. Then now the bony contours of the knee joint usually contribute little to the stability of the joint, but the intercondyle eminence of the tibia usually prevent the sideways slipping of the femur on tibia. So that is one. Now, also, the ligaments and the muscles um, make this joint a very stable joint, which rarely dislocates. So therefore, we need dislocation unless the trauma was really bad. Now, the cruciate ligaments, okay, they are indispensable to anteroposterior stability of the joint. Okay. Now, as I have said earlier, the forward or the anterior displacement of the tibia on femur is prevented by the anterior cruciate ligament, and the posterior displacement of tibia on femur is prevented by the posterior cruciate ligament. Therefore, the integrity of the posterior cruciate ligament is very, very important, especially when climbing downstairs or climbing downstairs. What am I saying? When walking downstairs or downhill. Also, the strength and the action of the surrounding muscles and tendons, especially the quadriceps tendon, dynamic, that's the dynamic factor. Then the others are stability factors. Remember the knee menisci, I've said they usually increase the concavityness. So they make the tibial condyles to be more convex for them to be congruent with the no, they make the tibial condyles to be more concave so as for the convex femoral condyle to, to fit, for them to be congruent. Now, neurovascular supply of the joint, blood supply. Blood supply is by genicular anastomosis. Then, intracapsular structures are supplied by the middle genicular artery, okay? So, the genicular anastomosis. Genicular anastomosis, I will do a video on it, but you should know the arteries forming the genicular anastomosis, all the genicular branches from the popliteal artery. We participate. But we have one genicular artery, the descending genicular artery, which arises from the femoral artery before it passes the adductor hiatus. It's the only genicular artery which does not arise from the popliteal artery. Now, nerve supply. We have the femoral nerve supplies the joint through its branches to the three vasti, vastus medialis, vastus intermedius, vastus lateralis. Also the sciatic nerve by the genicular branches from both the tibial component and the common peroneal or the common fibular component. Then we have the obturator nerve through its posterior division, and that continuation, that branch from the posterior division, which is known as the middle genicular nerve, is the one which will pierce the oblique popliteal ligament to supply intracapsular structures. Okay, now relationships. Now, anterior to the joint, you have the tendon of quadriceps femoris, patella, ligamentum patella, the patella plexus of nerves, and the patella synovial bursa. See them. Then anteromedially, we have this is the anteromedially here. Here we have the medial patella retinaculum. Anterolaterally, you have the lateral patella retinaculum and the iliotibial band. Posteriorly, we have the structures in the popliteal fossa, okay, and also the oblique popliteal ligament. Posterolaterally here, you can see we have in the upper part, you have the tendon of biceps femoris, common peroneal nerve. In the lower part, you have the lateral head of gastrocnemius and antalis. These are the structures which form the lateral, both the anterolateral, both the superomedial and these are the structures which are forming the superolateral and inferolateral boundary of the popliteal fossa. Then posteromedially, we will have the structures. We have some of the structures forming the superomedial boundary of popliteal fossa, and also you have the gyropes, sartorius, gracilis, and semitendinosus. The three of them are known as the gyropes. Okay, and remember they insert via a common tendon to the medial aspect of tibia, the pes anselinus tendon. Now, which are the movements of the knee joint? You have flexion. Flexion, the chief muscles of flexion of the knee joint are the hamstrings, assisted by popliteus, which initiates. You have the sartorius, gracilis, gastrocnemius, taris. Now, extension is mainly by the quadriceps femoris, the four of them, vastus lateralis, vastus intermedius, um, vastus medialis, and the rectus femoris, assisted by the tensor fasciata, via the iliotibial band. Medial rotation is by the semitendinosus, semimembranosus, and popliteus, assisted by sartorius and gracilis. Lateral rotation is mainly by biceps femoris, assisted by gluteus maximus and the tensor fasciata via the iliotibial band. Okay, so we have come to the end of that session, and thank you for your attention. And please subscribe for more anatomy and biochemistry content. Thank you.